today's Western Galilee Central Area Consortium and Budapest Partnership Together Social Workers Zoom lecture. I'm Heidi Benish, the coordinator of the medical committee of the partnership, and I've been working for this lively partnership for 20 years. The lecture of today is the second in the partnership ongoing professional Zoom meetings for social workers. If you are new to the partnership, it's a program of the Jewish Agency and the Jewish Federation of North America, promoting people-to-people relationships through cultural, social, medical, educational, and economic programs. Our partnership is between 16 communities in the United States and Budapest in Hungary and the Western Galilee. Today, we are more than happy to have you here with us. We have participants from Austin, Fort Worth, South Bend, Northwest Indiana, Buffalo, Dayton, Louisville, Youngstown, Budapest, and the Western Galilee. I'm excited to introduce you to my dear colleague, Sharon Mann, the International Liaison at the Galilee Medical Center. Thank you. Sharon, yours.
Okay. Hi, everyone. Hi, everyone. It's good to see all of you. Okay, as Heidi said, I'm the coordinator in the Fire and Affairs Department, and I work with Heidi on the partnership under Aya Kagata, who is the director of our department, and she's also the co-chair of the medical committee for the partnership. I want to thank Hannah Solomon, the director of the Galilee Medical Center Social Work Department, for all of her efforts and her collaboration and energy in our programs, and all the members of her department who are with us today on this Zoom call. I want to thank also Heidi and Gil from the partnership for all their work, and everyone else for joining us. Please introduce yourself and write any comments or questions that you have in the chat feature. And also, now I want to just tell you a little bit about our speakers today. Salit Edwards is the Deputy Director of the Social Work Department, and she's really worked hard to prepare today's presentation. As part of her Master's of Social Work Studies at Tel Chai College, she focused on trauma and resilience with Dr. Moshe Farchi, who developed and established the 6 C's model to treat trauma. And she underwent training to teach the model to others. I also want to introduce Shachar Peretz, who is one of the social workers in the department and has been nominated and also volunteered to put her forth her best efforts to convey the presentation on behalf of Salit and the department in English for all of you today. So Shachar, it's all yours. And I just want to remind everyone and myself as well to try to keep ourselves on mute, you know, most of the, unless we have a question or something. And thanks again for joining us today. It's yours, Shachar.
Well, hello, everyone. As Sharon has said, I'll be mainly translating this presentation. Salit is the actual expert for everything trauma in our department. So she's going to jump in whenever either I say something incorrectly or she wants to kind of speak more about the subject. So we will talking in unison sometimes. So let's begin. Okay. Right. Wait, numbers are over. Okay. As Sharon has said, the 6 C's model is basically the larger model. Today we're going to speak a little bit more about the concentrated model. We call it the ACT model. We'll talk a little bit. We'll talk about that a little further down the road. But what we need to know before we start everything is that this model, this concentrated model, is meant to treat an immediate and acute stress reactions and trauma events. We're talking about the first 48 hours after the traumatic event, and we'll speak a little bit more about trauma in a second. So what is trauma by the DSM? It has two main factors: the existential threat, like the actual event, and helplessness, the perceived feeling of helplessness by the individual experiencing the event. These two combined eventually create more panic and more fear, creating an interpretation of the event as traumatic. For instance, if we have two people riding a car together, coming to an intersection, witnessing a horrific car accident, one person sitting there, person A, would look at the event, get into a state of shock, won't be able to move, won't be able to speak. The other person, who has a job in this site, is a medic. He'll jump out, take his medic bag, and start treating people. The difference between two people is not only the interpretation, but the function in that specific event. So what happens when we interpret the event as traumatic? Basically, we start showing more and more signs of acute stress reaction, ASR, as we all know, making the feeling of helplessness feel greater and greater, and eventually causing more fear, more panic, more symptoms of acute stress reaction, and creating thus a helplessness circle. So before we go on a bit further, we want to ask everyone what they think. If we have a person, we're trying to treat someone with that kind of reaction in the field, what would be the best channel of communication with them? Will we do the more emotional route? Will we talk to them about what they're feeling, try and hug them, try and cuddle them, try and take them away from the situation? Or will we try and concentrate on more intellectual functions? Try and be factual.
Communication.
Anyone like to?
Someone want to?
All right. So first things first we need to talk a little bit about the brain in this situation. We have two parts to the brain that are relevant to the story. The first one being the amygdala. The amygdala is basically the emotional response center of the brain. Everything that's emotional based and the more animalistic parts are in that center. Basically, all the F reactions that we're all taught and we all learned at some point of our career, they're all presented there. And specifically and we'll talk specifically more about the freeze reaction. The other part of the brain that we want to talk about is the prefrontal cortex, sitting right over here. The prefrontal cortex is the executive decision making. It helps us interpret the situation, make proper and intellectual decisions. What we want to do basically is move the activity in the brain from the amygdala to the prefrontal cortex. We want to make proper decisions. We want to engage in the situation in a more cognitive manner than the animalistic, emotional part of our brain. So what happens when we approach the situation on an emotional-based communication? Basically, first we have the actual event. It's causing us stress and anxiety. So what we want to do in the most basic manner, the most instinctive manner actually, we're trying to calm. We might tell the person to sit down. We'll give them water. We'll ask them how they're feeling. We'll take them away from the event. Thus, we'll create more activity in the amygdala, more emotion. We start reducing the forebrain activity and we reduce our ability to make proper decisions. Further down the road, it will create a bigger feeling, an increased feeling of helplessness, and we will reduce more and more the functional capacities. We will no longer be able to function in a proper manner. Eventually, we'll start responding to the situation by interpreting it as traumatic, and thus creating more stress, more anxiety, and going through the circle over and over again until we create a fixation of the feeling of distress and inability to function. But what happens if we try it in another way? first things first, if we try and work through the rational communication route, we'll have the anxiety again, but we're trying to engage by mental speech activation and adapt the abilities. We reduce amygdala activity, increase forebrain activity, and thus increasing our ability to make actual decisions. More and more, we start feeling less and less helpless, and we start increasing functional capacity and reduced interpretation of traumatic experience. Then we'll basically jump over the stress factor because we'll feel more and more able and capable of dealing with the situation. So what happens is we can return to our functional abilities better, quicker. So the ACT model, just to make sure that everyone understands, is a reduced model of the 6 C's. The ACT model is basically a translation of the word in Hebrew ma'aseh, which are the initials for the model. It has 3 stages and 1 pre-stage. So we'll start with the pre-stage.
And the goal of all this model is to get the person as quick as we can to function again and to prevent PTSD, post-trauma, in the long term.
So what happens first? The person, what we want to do first, we want to combat the loneliness factor. A person sitting in an ER full of people, noise, smells, everyone is jumping, everyone is screaming, everyone's talking, we'll still feel lonely in the situation. We'll feel incapable, we'll feel like no one sees us, we feel like we're not contributing to the situation. Therefore, we want to combat it by doing the very, very basic thing, which is showing and express commitment in a very forefront manner. We'll come over and we'll introduce ourselves and commit. We'll say, hi, my name is Shachar. I'm a social worker in the hospital. What's your name? When you get the name, well, I'll tell them, I'm going to stay with you through this till the end. Why is that? Because A, we're trying to, again, tell them you're not alone. You have someone, you have a person in this space, but also we want to try and focus them onto me. I want them to engage with me instead of being drowning inside that room. All right, the first aid principle, this is we said that the commitment was came before the first aid. The first aid principle will be to activate the person effectively in the context of the event. What that means is we'll give them tasks. It'll be simple tasks, but effective ones. We want them to engage with the situation. We don't want them to do something that's outside of the room. We don't want to send them on a needless hunt for something. We want them to do something to make them feel helpful, meaningful, and try and rebuild their confidence. So what we'll ask them, for instance, is that, can you call someone and tell them that you're here? We won't hand them the phone. We won't call for them. We'll tell them to do that. We won't give them water. We'll tell them to pass out water to the other people in the room. We'll ask them who was with them. Can they identify the people who were in the event with them? Can you please count for me how many people are in the room that came with you on the ambulance? We'll do something to make them stay in the situation, but manage it. Again, the focus will always be on the function. So while they're engaging, we won't take them out, because then again, we'll increase the helplessness. So always stay in the room, always do something, even if it's right on the edge of the actual event. The second principle will be communicating with the person through a cognitive channel. Again, there's no room for emotion in this specific model. The emotional part comes later. Again, we're staying in the 48 hours time limit. We won't ask them how they're feeling about this situation. We won't tell them something like, it's very hard for you. I feel that you're very sad. I feel that you're very upset. We won't engage with that emotional reaction. We'll always talk through the cognitive channel. So before we get to the third part, the eighth principle, sorry, we need to talk a little bit about the memory, because we're going to build the sequence of events. So what happens to the memory at that kind of situation? Obviously, a lot of people will feel very, very confused. Everything's happened at once. You can't remember what you want to do. You lose basic functions and basic abilities that you used to have. You feel like everyone's watching and feeling like you're not doing anything right. And basically, we want to counteract it. How we do that? Sorry, before we get to how to do that. Why does that happen? Well, at the event, the stimuli, the senses basically start to get hyperactive. Our amygdala tells our brain to focus on everything, but you can't focus on everything. You can only absorb so much. So we hear everything, we smell everything, we can taste everything. Everything is happening in a very quick manner, high volumes of information overflowing the brain. So what our memory will do is try and drop parts of it. So we get the arousal and the sharpness of the senses. We'll get overabsorption of stimuli, and we get an abnormal memory load. So our brain basically wants to get back into function. So what it does, it says, I can't really do this. This is too much, and start dropping parts of the memory in order to help us. Exactly, and start confusing between them. We get the middle in the end, and the end at the beginning. We start making a mishmash because our brain is basically drowning in information. So we get up, there's a problem in putting everything that happened in order. So how do we combat that? No. Okay, so we start restoring the sequence of events. We will summarize it. The beginning will be, tell me what happened. We will listen to the story. It'll be it's a very important part, because we basically want to try and understand the perimeter of the actual story. We will help the person focus on the facts. Again, we will not talk on an emotional channel. What happened? Who went where? This started in this hour, if they can do it. It's not, they don't always can. And try and make order through things based on facts. We'll try and maintain a chronological order. And again, eventually we'll ask them to retell the story through that order. Basically what will happen is we'll get a bunch of jumbled information. The story won't make sense, but we'll tell them the fact, what happened, then this happened, then this happened, and now you tell me the story again. And we go through it again and try and see if we can find any problems in the story again, until we can basically fix it. So we will begin always by what happened in the minutes prior. You were going to Carmiel or to Tel Aviv to buy shirts, okay? You got in the car and you started driving there. Then in this intersection, this and this and this happened. And then you came to the hospital, and now you're being treated here. And then we will say the event is done. We will always say that it's finished. We'll try and emphasize this, because many times the person won't be able, again, they're very confused. They won't be able to put a finish to that story. So we'll do that for them. And then we will emphasize what's going to happen next, because we need to help them try and see further from the traumatic situation, because it's done. Now something else is going to happen, and it's not going to be traumatic. So you went from point A to B. You had an accident. An ambulance took you to the hospital. You came to the hospital. You were treated by this person and that person. The event is done. Now we're going to finish our conversation. The doctor is going to come over, see you over, and then you're going to get discharged. You need to call your mother, your father, your friend, who's going to pick you up. Who do you want to call?
Even if it's not happened in the hospital, on the road, near the accident, the person is very confused. He's talking only about the accident. Now someone crashes into me. We also stop and tell him, when was you going to be? Where did you go from? what happened. Now here the ambulance will come, they will treat you, you're not in danger anymore, and the event is finished. You're going to the hospital in a few minutes, or you're going home, and make everything in order. And the most important thing is saying that it's finished and you're not in danger anymore.
So, a quick overview about what we discussed so far. We have the factor of loneliness. We combat it by using proper and expressed commitment to the situation. Again, very important step. We should never, ever drop it from the model, because we need to focus the person and help them find the one person that they connect and speak to in that sort of a mess of an event. So we say, hi, my name is, what's my job what's my profession, or what I do in this place. Ask them for their name. It's very important to identify the name. It's a channel of communication. And then we'll tell them, hi, I'm going to stay with you till this is done. Next, we have the helplessness factor. We will encourage effective activity. We'll tell them to do something that's going to be meaningful and part of the situation happening around them. We have the emotional overflow. So we will ask questions that require a little bit of thinking. Something with numbers would be great in that kind of situation. How many people were you in the car, for instance? When we have confusion, we will help them build the sequence of events, again, focusing on the chronological order, on the facts of the situation, and eventually we will finish it for them. We'll tell them it is done, you're no longer in any kind of a threatening situation, and we'll tell them what's going to happen next. So just to put things in order, so you can jump in anytime. We are moving from emotional-based communication that's very passive, because what happened to you instead of what you're doing right now, how you helping yourself get out of this very traumatic event. Moving from that to an action-based and cognitive channel of communication.
I want to just say that the two goals of this model is one, to move the person as quick as we can to a functioning situation, and the second is prevent PTSD in the long term. And for that, we put the story in order, because otherwise he may stay in the situation of the event, and if it's not finished, he will stay there. And in the long term, by dreaming or flashbacks, he will relive the situation, and that can cause PTSD or chronic PTSD, which is much more difficult to treat. This time is the 48 hours from the event. We have to do this, and it takes a few minutes to move the person from this chaos and the feeling of not functioning to functioning.
All right, so we have a quick video for guys.
It's in Hebrew, but you can read.
Yeah, there's a translation at the bottom.
בשיתוף המכללה האקדמית תל חי מציגים הנחיות להגשת עזרה ראשונה נפשית במצבי מצוקה שונים. כל אחד מאיתנו יכול ומסוגל לעשות מעשה ולסייע לאדם הנמצא במצוקה נפשית. יש לפעול על פי 4 העקרונות הבאים. מקד את האדם בקשר עמך. בעת מצוקה מתעוררת תחושת בדידות, לכן צור מחויבות דרך אמירה. אתה לא לבד, אני איתך. צפו בדוגמה הבאה.
שתי מים, רותם, תרגי, די. הכל בסדר, הכל בסדר, רותם.
מצוקה מחריפה בדידות. הדגש מחויבותך לנפגע, ואמור לו שאינו לבד.
מה קרה?
היא ראתה את התאונה.
שלום, לי קוראים שירלי, איך קוראים לך? שלום, לי קוראים שירלי, איך קוראים לך? רותם. תקשיבי, אני איתך ואני לא עוזבת אותך. קומי. תובילי אותי חזרה לכיתה שלך.
עודד פעולות יעילות ופשוטות. חוסר אונים מגביר מצוקה. עודד את האדם לביצוע פעולות יעילות ופשוטות כמו לספור את האנשים שעימו, לאסוף מספרי טלפונים, להתקשר לקרובי משפחתו. צפו בדוגמה הבאה.
הכל בסדר. מה לעשות? תירגעי. מה? אני לא יכולה להירגע, לא חיזר, אני גם אבל. זה לא יעזור. אבל לא יכולה להירגע.
חוסר אונים הוא אויב. אל תרגיע, תפעיל.
אני מנסה, אני לא מסוגלת. לא יכולה, אני מפחדת. אבל תירגעי.
ולא, תקשיבו אליי בבקשה. יופי, אני צריכה את העזרה שלכם. את מיכל, בבקשה, תעמדי ליד הדלת, תספרי את כל התלמידים שנכנסים. את, דלית, תעמדי ליד, תפני אותם לישיבה ליד הקיר ההוא.
לשם.
שאל שאלות פשוטות המאפשרות חשיבה ובחירה. הצפה רגשית מגבירה מצוקה. הימנע משאלות על רגשות ושאל שאלות פשוטות אודות האירוע, כגון כמה זמן אתה כאן? להיכן אתה צריך להגיע? תרצה להתחיל בנסיעה או קודם להתקשר למשפחתך? צפו בדוגמה הבאה.
מה קרה? אשפזו את האח שלי. מסכנה שלי. אל תדאגי, הכל יהיה בסדר. תבכי, זה משחרר.
מצב חירום מחייב חשיבה ותפקוד. שאל שאלות פשוטות ועודד פעילות יעילה.
טל, תרגע. יובל, תסתכלי עליי. איזה בית חולים הוא? הוא בתל השומר. את רוצה שנתקשר להורים או שניסע לשם ישר? שניסע לשם. אוקיי. המפתחות עלייך? המפתחות של הרכב? כן. את זוכרת איפה השארת את האוטו? כן, השארתי אותו שם.
הבנה את רצף האירועים. אדם במצוקה סובל מבלבול, מתקשה לעתים בדיבור ואינו זוכר מה קרה. תאר את רצף האירועים שהתרחשו כדי ליצור סדר ולהפחית את הבלבול. הדגש כי האירוע המאיים הסתיים. צפו בדוגמה הבאה.
אחי, מה קרה לאילן?
לא הצלחתי לזוז. אני לא מבין מה קרה. הוא נפל.
עזוב, שכח את מה שהיית.
בלבול מחריף מצוקה. שחזר את רצף האירועים, והדגש כי היו מסתיים.
איציק, תסתכל עליי. ישבנו ארבעתנו במסעדה. אתה ואילן יצאתם והוא התהלך. עכשיו כבר מטפלים בו. בערב נלך לבקר אותו.
נראה לי שזה רעיון טוב.
תתקשר לחברה שלו בינתיים, תעדכן אותה.
כן.
חוסן נפשי, זה בידיים שלנו.
All right, so before we finish off and discuss this, we know that there's somewhat of a paradigm shift or something that's very counterintuitive in this model. So again, we need to preface this. This model is meant to be used 48 hours after the exposure to that traumatic event. Afterwards, we'll start talking a bit more through the emotional channel and start basically breaking down what's happened and start our treatment process. But in these 48 hours, we're going to try and focus our effort in this model, through this model, by preventing PTSD and returning to function. Basically, we're thinking ahead of what's going to happen in 3 months from now when symptoms of PTSD might develop. So before anyone gets angry, just so you know that. Salit?
Thank you. I think, I hope you saw the little film and you understood because it was in Hebrew.
Yeah.
And thank you for listening. And if you have questions or you want more examples,
now's the time. Thank you, Rasulman.
Okay, thank you, Salit and Shachar. I don't see any questions in the chat. Does anyone who's on want to ask one, either unmute yourself or write something, or have any comments, or maybe a comparison to a different way, whatever your thoughts are? Anyone want to jump in?
Hi, this is Sharon from Dayton, Ohio. Thank you so much for that presentation. It's so great to see each of you. I just remember my time with you very fondly. I think for me, what you said at the end is really important. I think as social workers, it can be a little counterintuitive because you want to connect with somebody relatively quickly, and that emotion is there. And so, I appreciate it is going to be kind of a little bit of a mind shift. And I wonder if you could talk a little bit about that just within your own department, because I'm sure that you've presented this information, and how has that just created a little bit maybe of a paradigm shift. And I think the other thing I have to keep in the forefront of my mind is that your focus is really within that 48 hours of the trauma. So either within the emergency department, or if the patient or the client does come into the hospital, kind of what that looks like.
Okay, so I just want to say that Dr. Farchi, who developed this model, started it in
2014. In Gaza, Israel, another Gaza, Israel war altercation.
To soldiers that experience traumatic events in the middle of situations there. And we found that he found, and we of course we continue to make a lot of research of these reactions, and he found that if you don't treat immediately in the field and let people stay in the situation and go on, or send them home, they will create they develop a really bad
eventually they'll develop all kinds of stress reactions culminating in PTSD and further CPTSD, which is very, very, very hard to treat, as everyone knows here.
So we know that what happened if his friends die in front of him, for example, or if someone died in a car accident in front of you, we won't take the catastrophic events that happened, but we will do a closure. And if we get the emotion, control the situation, we can arrange it. The brain will be overflow, and it will come back again and again and again to the moment of the event, and won't let it go. And it's have a bigger effect for the rest of the life, because we try not to get flashbacks, and we can control it. So we start getting to a depression and not going out of home, and try to avoid meeting the situation again, even if it's a noise outside, and really it's destroyed their life. And we see at the emergency room again and again that when we treat people for the first minutes in this model, they will come back to function. And then afterwards in the clinic, we can talk about emotion and everything. But if it's at the beginning, we want to put it in order and get them to function immediately, we will we will make the situation worse and worse, and the people probably will suffer for the rest of their life. We also, at the beginning, and even me at the university, when we started it, all the social workers that was there, try to even argue with the professor about this model and how can you ignore the emotion, and he's crying, I must connect to him.
Actually, I had the same reaction when you taught us the model. I was in a complete state of shock. I thought it was inappropriate even at times, because we started acting the situations out, and it felt bad. It felt like I was doing something damaging. But later on, you moved us into real life situations, and Salit is the overruler of trauma here. So when events happened, you guided us actual time in the event, in those situations, in the ER, in the different departments.
And we're not saying that at the long term, we won't talk about the feelings and going on with the treatment, but not at the first moment of the event, because it will make him more and more in feeling of helplessness, which we know won't help him to get over the trauma and even increase it. If you want an example,
give
I
them
had an example.
Ali, just a moment. Please give some examples, and all the staff that had the experience with this model, think about it and give the examples also. It will be helpful to understand it better.
Okay, so I will start with a nurse, a head of the nurse in an emergency room that I was called to help her after an event that people from outside of the emergency room came and they hit really hard the manager of the emergency room, and she was working with him, and when I met her, she was not functioning, crying. It was I think half an hour after the event, sitting in a room, closed door, crying, not functioning, very, very excited, and everyone went in and hugging her and trying to calm her down. And I came in. She knows who I am, but I'm just saying I'm with you here. And I asked her what happened. She was very confused. And the most important thing that she said, I wasn't doing anything. I couldn't do anything. And I let them hit him, and I didn't do anything. And then I told her to tell me the story from the beginning. A few minutes before you was working there, and what happened, and afterwards what happened, and then I told her the whole story again. First of all, I told her, you can open the door and look at the manager. He's back to work and it's all over. And I show her how she did help. I tell her, I hear in your story that you were screaming. Okay, you didn't push the button that you should because she was confused, but you scream, and in a few seconds, all the security was here. You pushed in your body all the people back to the back of the emergency so they won't get hurt. And I told her, now I want you to call another nurse that was there and talk to her to see how she feels, because you are the manager. So I gave her something to do. I told her to tell me how many people was injured, so she should count. And I told her, you're not going home, you're going back to work, because we get people to go on and function, otherwise they will be traumatic. And I think I worked about 10 minutes with her, and she was working again as usual. I'm not saying what's happened is not sad, frightening, bad, but for her, if I was cuddling her, tell her, like we used to, every one of us, it's very hard, and I know what you're feeling, and it's normal that you're crying, I would increase her helplessness and feeling that she's guilty and can't function. This is only one example. We have example with kids a lot of time. And if any one of the staff want to give another examples, I have many more, but I will be happy.
Sorry, I'm going to speak with Hebrew a little for a moment. מי שמרגישה יותר נוח לשתף בעברית, אז שרון או היידי יעזרו בתרגום, אז בבקשה, תרגישו חופשי ותשתפו. אני חושבת שיש לכם המון דוגמאות.
גם על אירועים שונים מתאונות זה חשוב, בגלל זה הבאתי את המקרה.
כוננות, תאונות, כל מה שאתם מרגישים.
Leanne mentioned that about the big bus accident with all the youth and the children, which took place, I think it was maybe a couple of months ago. Maybe someone wants to describe how you used the model in that incident. It really involved a lot of children, and it was a big trauma. So does someone want to describe that, or Salit, Shachar, Leanne?
גלית, אחרות, כל מי שהייתה באירוע.
Salit, it is okay that I will explain about the event? So we called to the hospital. It's called the Iran. I don't know how we called it in English, but it's a huge event, an emergency event that we had.
It's a mass casualty event.
Yeah.
Okay.
So it was a huge accident with a bus full of religious children living far from here. And we came to the emergency room. There was a lot of children because their parents lived very far, and until they get here, it took some time. And what Salit and Shachar was talking about, it was exactly the same thing. You need to concentrate the children and to focus them on the event itself. Okay, let me know what happened. And now you are safe. You are in a place that you are taken care of. And it was really helpful for the children to get focused and to minimize the traumatizing. Because when you do this thing, especially with event of a lot of people, and Salit was the one that ruling everything and helping us to engage all the children and to try to minimize the traumatized and the feelings. Of course, there were little children, like from not toddlers, but I think 4 till 12 till 18 even. But all of this model is, we did the same thing with all the ages, even with the adults that came. I can give one example of a little girl that one of the staff just tried to tell her, it's okay, little one, you can cry, you can even touch your face and feel sorry for yourself. And then I just took my hand gently and moved it back and said, I will take it from here. You don't need to cry right now. Let's try to focus. What about your day? Are you here right now? We are going to the CT and they're going to check you. And just going with the face with her to minimize the staying in this horrible trauma, because it was an awful accident for the children. and we try to be them for there. And but I have to say that the doctors and the nurses and all the staff gave us the platform to do that. Sorry that I talk too much, but thank you so much.
Okay, there is a question here, I see.
Someone asked, do these techniques work for PTSD for long after the event? Salit?
So, no, PTSD, it's a year after the traumatic events start to be PTSD, and it's along a different treatment in the clinic, not in the place of the event, but we do use a few of the techniques, like telling the story and make it in order, and make people feel success in what they're doing and start doing stuff, because usually they are very unconnected and try to avoid everything because they want to not be in contact with the world around that remind them all the time of the events in many ways, even noises or smells. But it's very hard to treat PTSD, and that's why we try to do these things around the event.
I can share one of the patients that I have at the moment at my department that he has.
Your name? Elior, תציג את עצמך.
Oh, hi, I'm Elior. I'm the social worker of the ICU in the Galilee Western Hospital, and at the current moment, I have a patient that is currently intubated, and he has I don't know how to say it in English actually, but he has a breathing machine that helps him, and he's sedated. At the moment, his family is the people that I connect with, and I've talked with them, and his son found him lying on the ground, and he puked all over the floor, and he has trauma, and he has like, he told me that he can't sleep, he can't even go to the house, he can't even eat well, and I catched him right at the moment of the 24-48 hours, actually after that happens, and I actually explained him this technique, and after I talked to him, his sister told me that he actually slept well in the next day. He ate well. He came to the house and cleaned all the house, and he washed everything, and he is coping actually better now that he knows that technique. And every time he pops up at the traumatic event that he saw, he's reminding him the same technique that I explained, and then he coped with it better, and he managed to even come and visit him, that he wasn't able to even get inside the ICU. So now he can actually enter, but not add the patient all the way, because he never even actually gone into the ICU before we talked. After we talked, he could actually got in, but not to see the patient because it's too traumatic for him. But that's one example that I can give live that I'm using today, and I saw the result today. So that's one way this technique actually works. So hopefully it will give a better example of what it looks like in the immediate term. And thank you.
It's a very good example, Elior. Thank you.
Thank you. I see that there's a question here from Christina, and she asked, do you feel like this perspective gives people a sense of control over the situation?
That's the goal.
The goal. So it, you all see it in action, basically, see that it works.
Shacha?
Yeah, that's the goal of the model. Because as we said at the beginning, trauma is a threat on one's life and feeling helplessness. At the moment, we activate them and they start being active. They take control of the situation. Sometimes it's in the emergency room or in the event, thousands or hundreds of people. And when we start even find someone of them and tell him, like you saw in the film, count the people, tell them where to sit, help me do something, they start to feel that they have control of the situation, and the feelings get a bit reduced and they feel a sense of control. It won't take what's happened and the horrible situation that sometimes we meet and see, but it's give the person a sense of control and ability to plan what he's going to do next and how he's going to deal with it.
Actually, I want to say something about this, because I feel that one of the greatest things that this model did for me is that it gave me, as the professional of the situation, it gave me a better set of tools, and it gave me an actual sense of control over things. Because again, I'm sure that even people, because I know I've been told that even people that have a lot more experience than I do, when you come into a situation like a road accident or even an ER that's full of children and everyone's screaming, there's a lot of smell, there's a lot of happening around you, you get lost in it, and it can be quite frightening, even as the professional. This model has a couple of stages for the professionals, for people who do that. Like there's an expand model for this, but I know that it gave me a lot of, it helped me feel better prepared, because I saw it in action and I saw what it did to me in that situation. And I can tell you that on a very personal level, I've experienced a lot less symptoms or even different forms of, let's call it secondhand trauma, because when you go to those events and you hear everything, even the stories are very hard to listen. Even the things didn't happen right in front of your eyes, everyone knows that you go home with the stories and the smells and everything just breaks through. And this model really helped me to put things into perspective and have a better sense of control over what happened to me as the professional in that situation. So that was for me a very unexpected result to working with this model.
In the research that I've done in my studies.
Salit, before you said about the research, I want to say something. The model is so simple that everybody can use it, even not professional people. The film that you saw was on the media, on the Israeli media, that helped. It was for the old people that helped them how to deal with these situations that we are dealing with them day by day. So it's very, very simple. It's used in the army, it's used in schools, it's used in a lot of places to deal with this situation that fortunately we in Israel have it a lot. And in the hospital, we are meeting every day a situation like this with people, with families, with patients, and it's like Shachar said, it's give us tools as a professional, as a social worker, to come to situation that we also sometimes feel helpless, and we use this model. It helps us also to be activity and help for the people. Now, Salit will talk about the research that...
in a few words, I wasn't going to get into it, but Shachar talks about it. The research that I've done and will go on doing these days is to see if staff that we teach them this model will יפחית, שחר, תעזרי לי פה.
Increase.
It will increase the symptom of traumatic, איך אומרים? Secondary traumatic.
סלית, דברי בעברית אם יותר נוח לך, וזה ייתן לך יותר.
שרון או שחר, תתרגמו אותי. המחקר שלנו לגבי המודל הזה, שברגע שאנחנו מלמדים אותו את הצוותים, זה יפחית גם אצלם טראומטיזציה משנית, וסימפטומים של הרגשת חוסר יכולת וחרדה במקצוע שלהם, שאנחנו יודעים שקיים. תרגמי.
שרון, את רוצה שאני...
לא תפסתי את הכל האמת, מה ש...
All right, basically what Salih is doing in her research, he's teaching that model, the expanded model, to a lot of people from many professions around the hospital, trying to decrease the amount of secondary trauma responses. She's currently looking into basically how effective the model is versus when people when used around the hospital in different professions. Basically, instead of just letting basically things go as they were until now, people just dealt with things, but people keep collecting secondary trauma. So we're trying to treat that by proving the model effectiveness by treating our staff and teaching them this tool.
Let me. We found for now that it's increased the secondary traumatic in high levels.
Decreases. Okay.
Decrease.
I just see that there's one more question which is short, and then maybe we'll conclude. The question is also from Christina. In the example of the school bus, how did you treat all the children if there wasn't enough staff? Can you?
It was enough staff. It was enough.
Okay.
We came, the social workers. Most of the social workers came to the hospital, and it was enough staff. It helped. Salit, if you want to say something more about this.
So the question is, can you treat more, like if there weren't, maybe could you treat several children at once?
Yeah, I think like you saw in the film, and I said it before, when you have many people than you on your own, or a little bit of staff, you find people in the crowd that you can see they are
you can try and find like central characters around the crowd, basically people who seem that seem like other people gravitate towards them, and
give them missions, so it will help them and help others and help you in dealing with the situation. Like please call the mom and the dad that their children was hurt, and take them to sit somewhere, and I'll come and talk to them. Teachers that collect the kids, count them, and when you give them missions and they help you, or tell them, go to them and ask them what's happened, and do the model. You can teach it in 3 minutes, and we done it. It's helped them and help the people, and give you more stuff to work with you.
So basically delegate responsibility among others, and that like basically increases the flow. Okay, I wanted
Sharon,
to, yeah.
Sharon, hi, I can tell about another example that I had 2 weeks ago.
Okay.
I had treated a young woman of 27 years old that she was hit by a car accident. She was hit badly, and she was hurt in her leg. She has been through some surgeries, and I met her about 3 days or 4 days in my department. I work at the orthopedic department. So I came to the department, and the staff told me that she had some HY attacks, and she's really very distressed, and they asked me to go to her and try to talk with her. I've been with her for about an hour, talking and reminding the event. And I can say I used the model. I used this model, but I used not all of the model, parts of the model, but it helped me and helped her actually to rearrange the event again. And I started to ask her, let's try to remind together. Where were you? What were you doing there? What happened when the car came fastly and hit you? Who was with you? And what did you? What do you? She was there with her father, so I asked her about her father. What did he do? And then I told her, but you are here now in the hospital. You have been taken care of, and in a few days you will be back home. Day after, I came to her, and she told me that she had slept very well. She's more controlled with her feelings, and until she went home, me and all the staff saw that she all the time mostly was laughing and more relaxed. So, and came to me personally and told me, thank you very much. You helped me so much. I feel more controlled. I can sleep well. I can laugh with my friends. She was very angry even to her family. She had two old parents and one sister. This is all of her family. And she was all the time, before I came to her, she was very nervous. She was shouting all the time on them.
נותקת, סבח. So, I want to say something else while Sabah is connecting again. I wanted to say more than Sabah said that when we learned first this model, we was very terrified. How can we use all this model? But we don't need to use all this model. We can take parts, and then step by step we can learn to use this model better. But it's helped even if you take some elements for the model and use them. So don't be afraid to use even part of this model, and try that. When you try that, when you will try it, and you will see the success, you will try it more and more, and be more qualified with this. סבח, סיימת? את רוצה להגיד עוד משהו? No.
Oh, my is so bad. I'm sorry.
Okay. יש לך עוד משהו להגיד? רצית להגיד עוד משהו? Okay.
I just to say the same things you said. It's very helpful. It doesn't fit for every situation, of course, and it doesn't fit everybody, but we can try it.
I'm not agree with you. It fit everybody. I think from your experience, I can hear that everybody, it fits them. Maybe some of them it will fit them more, and some of them it will fit them less. But it fits anybody. Unless I'm wrong, and Salit can correct me, but I think it fits anybody.
I think you're right, Hannah. Even at home, when children are afraid of something, I can ask what's happened and give them a little role. If you're afraid of, I don't know, the rain outside, you in charge of closing all the windows before we go to sleep. Thieves, whatever they're afraid of, and make them helpful. And I think that's will give them control of the situation. And I think everyone knows it from our life, from our everyday life. But we was taught differently to bring up emotions and to relate to it and not give the focus of functioning. And I think now that we know how to do it and why and what's happened in our brain in traumatic events, I think we're working at these events much better than we did before we start using it. Of course, it's not for everything. It's for traumatic events, immediate events, and very acute. It's not from a complex trauma. It's not for a PTSD or chronic PTSD. It's for these events. And I think, like Hannah said, if you try it, you see the difference in the people in front of you immediately, and you see how you help them. That's the main goal of our profession.
Can I just add one thing as also just maybe bring a closure? I know that the team at the social work department and other, I think through Moshe Farchi, they all use this model to coach the staff in the hospitals to help them with their own trauma dealing with the corona patients in terms of the whole pandemic and the ones who actually had to go into the corona departments. And so again, the model was adapted for a more complex situation, but I understand that it was very helpful through the pandemic.
Yes, of course.
Okay, so I would like to put a closure to this meeting. First of all, I want to thank all the staff from the Galilee Medical Center, especially to Hannah Solomon, the director of the social worker department at the medical center, to Salit and to Shacha for preparing this and giving us this very eye-opener lecture. I want to say thank you to all the participants who have been here for your questions, your remarks. I hope that this will help you. I can personally say I'm not a social worker. I heard this lecture in the past, and I actually have used it a couple of times. So thank you for sharing this with us. I know that some of you have asked if we can share the presentation. Sharon Mann and I will get in touch with Hannah and his staff next week and see how we can share this with you. Last thing, we are looking forward to invite you for our next seminars. We will keep you posted. This is just our second one in a line. And the very last thing, please stay in touch. If you have any questions, reach out to us. Stay healthy and have a wonderful day. Thank you very much. Yes.
Thank you very much. Miss you all.
Happy Hanukkah, you all.
Yes. We have time.
Thank you so much.
Bye-bye.
Bye.
Bye.
Take care.